Welcome to Last Minute Lecture. This free chapter overview is designed to help students review and understand key concepts. These summaries supplement, not replace, the original textbook and may not be redistributed or resold. For complete coverage, always consult the official text. Right now, roughly 1 in 3 patients walking into your clinic is taking a medication that has had absolutely zero FDA safety testing.
Yeah, it's pretty wild.
Right. I mean, they bought it online or, maybe at a local grocery store. It's just sitting in their medicine cabinet. And it might just completely neutralize the life-saving prescriptions you're about to write.
And, well, the most concerning part is that they probably won't even mention it to you unless you specifically ask.
Exactly.
Because, the product is labeled natural, so patients just inherently assume it's harmless. But from a pharmacokinetic standpoint, we know that couldn't be further from the truth.
Which is exactly why we are tackling this today. Welcome to the deep dive.
Glad to be here.
So our mission for this session is to review Chapter 71 of Lynn's Pharmacotherapeutics, and we are focusing entirely on complementary and alternative therapy, or CAM. Consider this your one-on-one clinical tutoring session, custom tailored for advanced practice nursing and physician assistant students. We're moving way beyond memorizing flashcards and really getting into the pathophysiology of these natural supplements.
Yeah, and to set the clinical baseline, let's use the National Center for Complementary and Integrative Health, the NCCIH definitions.
Okay, let's hear them.
So complementary refers to a non-mainstream practice used alongside conventional medicine.
Right, complementary means with.
Exactly. And alternative means it is used completely in place of conventional medicine. And the most common form of CAM you will encounter are dietary supplements, which the FDA legally defines as ingested products like vitamins, minerals, and botanicals intended to supplement the diet.
Okay, let's actually unpack that FDA definition because I feel like this is where the regulatory landscape turns into the Wild West.
Oh, absolutely.
Before you can safely prescribe a conventional drug like, a beta blocker or an SSRI, you have to understand that supplements are operating under a completely different set of legal rules. Specifically, the Dietary Supplement Health and Education Act of 1994, the DSHEA.
Yeah, DSHEA really changed everything. Because of this act, supplements are completely exempt from the rigorous premarket scrutiny required for conventional drugs.
Which is terrifying.
It is.
Yeah.
A manufacturer does not have to prove their botanical extract is safe, nor do they have to prove it actually works before putting it on a shelf.
Which, honestly, that just blows my mind. The entire burden of proof is flipped.
Yep.
Instead of the manufacturer proving it's safe to sell, the FDA has to prove it's dangerous after it's already being consumed by the public. And this legal gray area completely dictates how these bottles are labeled.
Right, because under DSHEA, a label absolutely cannot claim to diagnose, treat, or cure a disease.
So they can't write like protects against cancer or cures UTI.
Exactly. But manufacturers are brilliant at semantic hair splitting. They are legally allowed to insinuate benefits regarding the body's structure or function.
I see.
So instead of, cures urinary tract infections, the bottle reads, promotes urinary tract health.
Oh, that's sneaky. And patients read those function claims and naturally assume they are buying a targeted, FDA-vetted medical treatment.
Exactly.
Now, there have been some minor guardrails put in place since 1994, right? Like the 2006 Consumer Protection Act.
Yeah, that forced manufacturers to finally report serious adverse events like, a patient ending up in the ICU to the FDA within 15 days via the MedWatch program.
Okay, that's something.
And then in 2007, there was the CGMP ruling, the Current Good Manufacturing Practices, which aimed to stop mislabeling and prevent contamination with heavy metals or bacteria.
Right. And manufacturers also try to use a standardization process now, don't they?
They do. They concentrate an extract to ensure a set amount of a known active ingredient in every batch, which on paper that sounds great for accurate dosing.
But there's a catch.
There is a big catch. Extracting and isolating one specific compound often destroys other unidentified synergistic agents in the whole plant. So historical efficacy data based on the whole plant might be completely irrelevant to the highly processed extract in the capsule.
Okay, so that brings up a huge clinical reasoning question for me. If the FDA isn't testing these pre-market and standardization alters the chemical profile anyway, how can a clinician trust any brown glass bottle a patient brings into the exam room? Like, how do I know it's not mostly sawdust and lead?
Well, you have to train your patients to look for the seals.
Okay.
There are 4 private certification organizations that are the gold standard for verifying purity, identity, and potency.
What are they?
You have the U.S. Pharmacopoeia, or USP, Consumer Lab, the Natural Products Association, and NSF International. If a product carries one of those seals, it has survived rigorous third-party testing to prove that what is on the label is actually what is in the bottle.
That is something every single patient needs to hear.
Absolutely.
Now, let's talk about why we care so intensely about what's actually in these bottles. The core of our clinical fear is adverse interactions with conventional pharmacotherapy.
Yes, and that almost always comes back to the CYP450 enzyme system in the liver.
Right. The foundational interactions usually involve either inducing or inhibiting these isoenzymes.
Take St. John's wort, for example.
Right.
It acts as a very powerful inducer of CYP3A4.
I always visualize St. John's wort as like stepping hard on the gas pedal of liver metabolism. It forces the liver to process other drugs so fast that they are cleared from the bloodstream before they can even reach their therapeutic targets.
Which leads to a massive loss of efficacy.
Exactly.
And then on the other end of the spectrum, you have agents like echinacea, which hits the brakes. Echinacea inhibits CYP3A4.
So it slows it down.
Right. When you slow down that metabolic clearing process, conventional drugs build up in the blood, drastically increasing the risk of systemic toxicity.
Wow. And beyond pharmacokinetics, we have dangerous pharmacodynamic interactions too, particularly bleeding risks.
Oh, definitely.
Like if a patient is taking ginkgo biloba, feverfew, or garlic, they are actively suppressing their platelet aggregation.
Yeah, and if you then prescribe aspirin, warfarin, or heparin, you are setting the stage for a severe, potentially life-threatening hemorrhagic event.
Which is precisely why every single over-the-counter supplement must be reconciled at every clinical visit. No exceptions.
No exceptions.
So let's actually put this into practice. The text walks through a massive list of specific agents from A to Z. But instead of just reading them alphabetically, let's group the first block, apple cider vinegar, through cranberry by how they actually behave in the body.
I like that approach.
Let's start with the metabolic modulators and organ toxins. We see a lot of patients using apple cider vinegar for weight loss, right?
We do, and the mechanism there is actually supported by some research. Apple cider vinegar delays gastric emptying, which creates a feeling of satiety and blunts post-meal glucose spikes.
Well,
But the tablet forms vary wildly in acetic acid concentration compared to liquid forms. And more importantly, it frequently causes hypokalemia.
oh, and that potassium drop is a massive red flag if your patient is taking digoxin for heart failure.
Absolutely it is.
Because digoxin works by inhibiting the sodium-potassium ATPase pump in heart muscle cells, and it competes directly with potassium for the exact same binding site.
Right.
So if apple cider vinegar depletes the patient's potassium, there is literally nothing to compete with a digoxin.
Yeah.
It just binds unchecked, triggering fatal digoxin toxicity.
The pathophysiology paints an incredibly clear picture of the risk there.
It really does.
Another agent with severe organ implications in this group is butterbur. The American Academy of Neurology actually gives it a level A rating for migraine prevention.
Level A. Wow.
Yeah, it's incredibly effective. But the raw plant contains pyrrolizidine alkaloids, or PAs, which are highly hepatotoxic.
So liver damage.
Exactly. Clinicians must verify the patient is exclusively using certified PA-free products to avoid devastating liver injury.
Sticking with liver toxicity and women's health, we have black cohosh, which is traditionally used for menopausal symptoms.
Right.
The NCCIH says there is insufficient evidence to prove it works, but patients swear by it. If they take it, you have to monitor their liver enzymes closely.
And you have to actively differentiate it from blue cohosh for them.
Yes, because blue cohosh is a completely different plant, and it dangerously elevates blood pressure, ramps up intestinal motility, and actually induces uterine contractions.
Very dangerous mix-up. Moving from metabolic and organ impacts to central nervous system modulators, let's look at ashwagandha. It's heavily marketed for stress these days.
I see ads for it everywhere.
Right. It works by activating GABA receptors in the CNS. By opening those chloride channels, it hyperpolarizes neurons and dampens nerve transmission, which completely explains the calming effect.
But there are contraindications, right?
Big ones. You have to counsel against its use in pregnancy, as high doses act as an abortifacient, and in breastfeeding because it can increase maternal testosterone levels.
Good to know. Another major neuromodulator is cannabidiol, or CBD.
Yeah.
The FDA actually approved a specific prescription CBD product, Epidiolex, for severe seizure disorders. It binds to cannabinoid receptors in the central nervous system.
But remember our CYP450 discussion.
Yep.
CBD is heavily metabolized by multiple CYP enzymes, so the drug interaction list is vast, and it causes severe additive sedation if combined with any other CNS depressants.
Rounding out this first group, we have agents targeting specific cellular and structural pathways, coenzyme Q10 and cranberry. CoQ10 is a potent antioxidant crucial for ATP energy production.
And the clinical relevance here is deeply tied to statins.
Right.
Statins work by inhibiting the H&G-CoA reductase enzyme to lower cholesterol, but that exact same pathway is required to synthesize endogenous CoQ10.
So by fixing the cholesterol, statins accidentally starve the muscles of CoQ10.
Exactly.
That mechanism completely explains why patients develop statin-induced myopathy and muscle pain. Oh, and structurally, CoQ10 looks incredibly similar to vitamin K2.
Which means it will directly antagonize the effects of warfarin.
Right. As for cranberry juice, which is used to prevent recurrent UTIs, the mechanism is purely structural. It contains proanthocyanidins.
Right, the PAKes.
Yeah, I picture those like a Teflon coating for the bladder wall. They physically block the bacteria from adhering to the urinary tract. But we really have to dispel the myth right now.
Please do.
Cranberry does not acidify the urine to kill bacteria, and it cannot treat an infection once it has already taken hold.
It's purely preventative.
Exactly.
Well, let's transition to the next block of agents in the text, covering echinacea down through glucosamine. A significant number of these carry the massive bleeding risks we mentioned earlier.
Right, specifically feverfew, fish oil, garlic, and ginkgo. Let's break those down. Feverfew is used for migraine prophylaxis, driven by an active compound called parthenolide.
But commercial variability is huge with that one.
Right, some bottles contain 0 parthenolide. Regardless, because it heavily suppresses platelet aggregation, you must instruct patients to discontinue feverfew 2 full weeks prior to any elective surgery.
Garlic operates similarly. It's taken for cardiovascular health, but it actively inhibits thromboxane synthesis.
And thromboxane A2 is a powerful promoter of platelet aggregation.
Right, so blocking it creates a significant antiplatelet effect. Garlic also drastically reduces the blood levels of conventional drugs, like the immunosuppressant cyclosporine.
Then there's fish oil. It decreases platelet aggregation to prevent thrombosis.
But interestingly, while the American Heart Association strongly recommends eating dietary fish twice a week for primary cardiovascular prevention, they explicitly state that fish oil supplements do not offer that same primary prevention benefit.
That is such a key distinction. And ginkgo biloba, well known for causing vasodilation, is widely taken to improve memory.
But the evidence here is definitive. The NIH-sponsored GM study, the Ginkgo Evaluation of Memory Study, tracked over 3,000 older adults for 6 years.
And what did they find?
The results prove that ginkgo completely failed to prevent dementia or cognitive decline. Furthermore, it actively lowers the seizure threshold.
Wow. So you absolutely avoid ginkgo in patients taking other drugs that lower the seizure threshold, like theophylline or tricyclic antidepressants.
Yeah.
Now, moving from bleeding risks to the immune and absorption modulators in this group. We mentioned echinacea earlier as a CYP3A4 inhibitor, but its actual target is the immune system. Patients take it to fight off colds.
Yeah, and while it stimulates immune function in the short term, prolonged long-term use is profoundly immunosuppressive. Research indicates it actually blocks CD28 signaling pathways.
Wait, I always have to refresh my memory on CD28. That's a T-cell mechanism, right?
It is, yeah. For a T cell to become fully activated to fight an infection, it needs 2 signals. The first is recognizing the antigen, but the second is a co-stimulatory signal through the CD28 receptor.
Okay, I'm with you.
Well, echinacea effectively unplugs that second signal. Because of this, prolonged therapy must be actively avoided in immunocompromised patients like those with HIV or tuberculosis and in patients with autoimmune diseases.
That makes perfect sense when you look at the pathways. A completely different immune target is elderberry, used for flu symptoms.
Right.
It actually decreases H1N1 activity by physically binding to the virions, stopping them from entering host cells. It's simple, with mostly mild GI side effects.
Speaking of the GI tract, we have to consider absorption blockers like flaxseed. It's a fantastic source of soluble fiber and phytoestrogens.
But that massive bulk of fiber can physically block the absorption of conventional drugs in the gut.
Exactly. Patients must be educated to take flaxseed either 1 hour before or 2 hours after their other medications.
Another GI agent is ginger root, famous for treating morning sickness. The mechanism here is fascinating. It blocks 5-HT3 receptors in the chemoreceptor trigger zone of the medulla,
which is the exact same pharmacologic mechanism as the prescription antiemetic ondansetron.
Right. Clinicians also need to know that ginger lowers blood sugar, meaning it will strongly potentiate the effects of a patient's insulin.
Finally, for this middle block, we have glucosamine and chondroitin, which act as substrates for cartilage synthesis in the joints.
Used for osteoarthritis.
Right. But the American College of Rheumatology updated their guidelines and specifically advises against using these for osteoarthritis management due to unconvincing efficacy data.
Oh, wow. They advise against it.
Yeah, and fundamentally, commercial glucosamine is manufactured from shrimp exoskeletons, making it a severe risk for patients with shellfish allergies.
Definitely a vital screening question. All right, let's tackle the final section of agents, moving from green tea through valerian. Let's look at the systemic cascades, starting with the hormone mimics. Resveratrol, saw palmetto, and soy.
Resveratrol is a phosphodiesterase inhibitor, but structurally it mimics estrogen, meaning it needs to be strictly avoided in patients with estrogen-dependent cancers.
Soy is similar, right?
Yeah, it contains isoflavones that bind directly to estrogen receptors. In postmenopausal women, they act as an estrogen agonist. Consequently, soy should never be combined with tamoxifen, which relies on blocking those exact receptors.
As for saw palmetto, which is taken for benign prostatic hyperplasia, the clinical evidence is incredibly clear.
Massive Cochrane reviews involving thousands of men show it is statistically no better than a placebo at reducing prostate symptoms.
On top of that, it carries a pregnancy category X risk because of its anti-androgenic effects. Right. So pregnant providers shouldn't even handle it crushed.
Right. Shifting to neuro and GI targets, peppermint oil is widely used as an antispasmodic. The American College of Gastroenterology actually recommends it for irritable bowel syndrome.
Because it successfully blocks calcium channels in the GI smooth muscle.
Yeah, but the delivery method matters entirely. If a patient drinks peppermint tea, it relaxes the lower esophageal sphincter.
It's like opening the floodgates for stomach acid, causing severe GERD.
Exactly. They require the enteric-coated gel capsules so the oil bypasses the stomach and releases safely into the intestines.
We also have probiotics, utilizing beneficial bacteria and yeast. A primary example is Saccharomyces boulardii, which produces proteases that degrade the toxins produced by C. diff. I sort of think of that like sending a bomb squad into the gut to dismantle the explosives, rather than fighting the bacteria directly.
I love that analogy. However, there is a massive safety warning here.
Let's hear it.
You absolutely cannot open packets of S. boulardii, which is often sold as Florastor, at the bedside of ICU patients with central lines.
Because the yeast can aerosolize.
Yes. It can settle on the line and cause a deadly fungemia blood infection.
That is terrifying. Other neuromodulators include melatonin and valerian. Melatonin mimics our endogenous hormone.
And while guidelines generally advise against it for chronic adult insomnia, the American Academy of Neurology strongly recommends it for treating sleep-disrupted behavior in children with autism spectrum disorder.
Good to know. Valerian, on the other hand, is a direct GABA agonist used for sleep.
But be sure to warn patients about paradoxical excitation with valerian.
Right. Sometimes it wires them up instead of calming them down.
Exactly. And you absolutely must prohibit combining it with other CNS depressants like alcohol or benzodiazepines.
We also have green tea and marijuana in this final block. Synthetic forms of marijuana, like dronabinol, are FDA approved for chemo-induced nausea.
But THC rapidly crosses the placenta and concentrates in breast milk, so it requires firm counseling against use during pregnancy and lactation.
And green tea offers chemoprotection via a compound called EGCG, but highly concentrated green tea extracts pose a severe risk for hepatotoxicity, and they can significantly decrease the absorption of the beta-blocker nadolol.
Okay, now we really need to address the most dangerous agent in the entire text, St. John's wort.
Oh boy.
This requires black box level clinical reasoning because it is a pharmacologic triple threat.
Okay, light up for us.
First, as we covered, it induces CYP3A4, clearing vital drugs like oral contraceptives and warfarin far too quickly.
Right. Second, it induces P-glycoprotein. You recall P-glycoprotein is an efflux pump located in the renal tubules and intestines.
Its job is to pump foreign substances out of the body.
Yeah, visualize it like a bilge pump on a sinking boat. By inducing P-glycoprotein, St. John's wort essentially installs 10 extra bilge pumps, aggressively accelerating the elimination of drugs like digoxin and calcium channel blockers, causing a total loss of therapeutic efficacy.
Spot on. And the third threat, it inhibits the reuptake of serotonin. If a patient takes St. John's wort alongside an SSRI or SNRI, they risk fatal serotonin syndrome.
It is an absolute contraindication to mix it with conventional antidepressants.
Period.
Okay, so we've covered the therapies patients might use with caution, but clinical reasoning also requires knowing what to actively prohibit. The text highlights the dangerous three.
Comfrey, kava, and mahuang, which is ephedra.
Right. Comfrey contains alkaloids that cause veno-occlusive disease, leading to catastrophic liver damage. Kava has been linked to liver failure so severe that patients have required full organ transplants.
And ephedra aggressively overstimulates the cardiovascular and central nervous systems, causing strokes, myocardial infarctions, and death.
Which is why the FDA took the historic step of outright banning ephedra.
Yep, they pulled it.
This makes absolutely no sense to me, though. If ephedra was banned by the FDA for causing harm, why are known liver destroyers like Comfrey and kava still perfectly legal for my patients to buy online right now?
Well, it all comes back to the retroactive burden of proof under DSHEA. The FDA cannot demand safety data before a supplement goes to market.
Right.
So to forcibly pull a widely used product like kava off the shelves, the FDA has to mount a massive, time-consuming legal and scientific case to prove it poses an unreasonable risk to public health.
And they only gather that data after people are already suffering severe liver failure.
Exactly. It is an incredibly slow, reactive process.
So what does this all mean for us as advanced practice providers? I mean, it brings us right to the patient education framework.
It does.
We have to consistently teach our patients that natural does not equal safe. Comfrey is 100% natural, and it will destroy your liver.
We must reconcile all over-the-counter supplements at every single visit.
And we had to do it without judgment so patients feel comfortable telling us the truth about what they're taking.
Right. And we should direct them to the NCCIH website for unbiased pharmacology data instead of, whatever wellness influencer they follow on social media.
Ultimately, the clinical reasoning framework you apply to CAM is the exact same one you use for conventional drugs.
Exactly. Understanding the underlying pathophysiology of how these botanical compounds alter enzymes, receptors, and systemic cascades dictates rational drug selection.
That pathophysiology drives safe dosing, diligent monitoring, and ultimately patient-centered outcomes.
Well said. That brings us to the end of our deep dive into Chapter 71. We hope this session arms you with the pharmacologic depth you need to confidently navigate the murky waters of alternative therapies in your clinical practice.
Before we wrap up, we want to leave you with one final thought to mull over.
Yeah, if a patient sits across from you and insists that a specific herbal supplement is drastically improving their daily quality of life, but a massive Cochrane review proves it's statistically no better than a placebo, how do you navigate that space?
Where's the line between strict evidence-based pharmacology and holistic patient-centered care? It's tough when they're off-roading in the dark, but as their clinician, you have to be willing to get in the passenger seat and help them steer.
Thanks for studying with the Last Minute Lecture team today.
See you on the next Deep Dive.